Hello everyone, this is Dr. Suraj here. Today we'll be talking about second heart sound and its splitting. So second heart sound, as we know, is because of aortic and pulmonic valve closure. Aortic and pulmonic valve closure. Now, if we see, this is our cardiac chambers and we have left atrium, left ventricle, right atrium and right ventricle. So you know this is what is our right atrium, which is connected with the superior and inferior vena cava, which are draining the venous blood into the right atrium. What happens during inspiration? During inspiration, as we know, that the intrathoracic pressure is negative. So it sucks more and more amount of the blood into the right atrium. Normally, this right atrium blood will go into right ventricle. From right ventricle through the pulmonic valve, this will be ejected out into the pulmonic trunk. But what happens in inspiration is, because the blood volume reaching the right atrium, so right ventricle is increased because of increased venous return. So what is happening? Now this will take more time to get ejected out from the right ventricle. Okay. So for that reason, the right ventricular ejection time is actually increased. Now, if the right ventricular ejection time is increased, does that mean that pulmonic valve should close early or late? If right ventricular ejection time is increased, that means this gate where the pulmonic valve is there, this should be open for a longer time. So the pulmonic valve remains open for a longer time. So you see, normally this is where the A2 closes, this is where the pulmonic valve closes, and that normal gap is your around 30 millisecond, which is the normal physiologic gap. But what happens in inspiration, because pulmonic valve, through the pulmonic valve, the right ventricular ejection fraction time is increased, this P2 is actually getting delayed. So now you can appreciate that now this P2 is actually closing after certain period of time. So thus this A2 P2 gap is increased. Okay, that is what is your normal delay during inspiration. That is what is physiological split. Next, coming to wide splitting of the second heart sound. What is wide splitting? Now please do remember that 30 millisecond is the normal gap. Anything less than 30 millisecond is your narrow split. So anything less than, so S2, the normal gap between A2 and P2 is 30 millisecond. And if the gap is less than 30 millisecond, that is your narrow split. Okay. And if the gap is more than 30 millisecond, it is what is your wide split. It is what is your wide splitting of second heart sound. Okay. So coming to the wide splitting. Wide splitting means here you can see that normally the gap is 30, now the gap is more. This is abnormally delayed. Now why that is happening? So this pulmonic valve is closing even after certain period of time. That is your wide splitting. Now see here, it is seen in condition where there is delay in RV emptying, like pulmonic stenosis, right bundle branch block, you will be having this wide splitting. Okay, now this wide splitting may be variable wide split, fixed wide split. It may be variable wide split. Variable wide split means the gap between A2 and P2 is actually changing. The gap between A2 and P2 is actually changing, and this is every time it is more than 30 millisecond. And fixed split, the fixed split of second heart sound is where the gap between A2 P2 is more than 30, so obviously, but it is fixed. It is not changing with respiratory cycle. So fixed means it is not changing with respiration is what is your fixed split. Okay, that is your fixed split. Now see the example. The fixed split you can see here, it is seen in case of ASD, atrial septal defect. Atrial septal defect may, yes, it is wide splitting, but it is fixed split. Okay, because there is left to right side shunting is there, and because of that the right atrium, then right ventricular volume is increased. So again the flow time through the pulmonic valve is increased, the same concept. Okay, and that increases a delay. Now why there is no why there is fixed splitting? Okay, why there is no respiratory variations? Okay, now to understand that we need to pay some concentration here. Supposing this is what is our heart. Okay, these are four chambers of our heart. These are four chambers of our heart. Now see, these are the two vena cava which are connected. Superior and inferior vena cava are there. Okay, and this side your pulmonary trunk is there. Okay, now what is happening during inspiration? Say I am talking about ASD. So there is an opening between the right atrium and left atrium there is a communication. That communication is atrial septal defect. Now first thing, what you need to know कि ASD and VSD में difference क्या है. ASD, that is atrial septal defect, and VSD, that is ventricular septal defect, that is in the interventricular septum. The difference is, the first is the similarity. The similarity is that in both the cases, guys, you will be having left to right shunting. That means these are acyanotic heart disease. So congenital heart disease में these are acyanotic heart disease. Okay, both are from left to right shunting, so there won't be any cyanosis. Okay, here my question is, in case of TOF, you have these four things na, and one is ventricular septal defect, large ventricular septal defect, and in this case the flow is from right side to left side na. The flow is from right side to left side, and that's why TOF is the most common cyanotic congenital heart disease. Why the cyanosis is there? Because of this right to left. VSD में right side to left side shunting is seen in case of TOF, and that is because of, you know, TOF का most important component क्या है? It's subpulmonic stenosis. Because of the subpulmonic stenosis, okay, the right ventricle में the blood is actually, you know, because of subpulmonic stenosis, now the right ventricle has to pump against a pressure. So gradual pressure building leads to right ventricular hypertrophy. Now supposing there is right ventricular hypertrophy, okay, there is right ventricular hypertrophy. So if there is right ventricular hypertrophy, then what happens? Right ventricle is taking lots of pressure, putting lots of pressure to pump the blood into the pulmonic trunk, and also there is subpulmonic stenosis, not pulmonic stenosis, subpulmonic stenosis. So all this thing is actually further increasing the pressure inside the right ventricle. So ultimately the shunt will be reversed from right to left. Okay, now the shunt will be reversed from right to left. Initially it is the left ventricle whose pressure was more, so the shunt was left to right. But now in TOF, because of development of this right ventricular hypertrophy and subpulmonic stenosis, actually first subpulmonic stenosis and then right ventricular hypertrophy, this shunt gets reversed. That's why you will see cyanosis not at birth. In TOF you won't get cyanosis at birth. Cyanosis is seen after 3 to 4 months birth. You will be seeing the cyanosis, because this is the time which will be taken for the compensatory changes like right ventricular hypertrophy or that thing. Now this is our associated discussion, but the difference in ASD and VSD which you need to know, कि VSD में it is high pressure में, there is high pressure gradient is there, but atria के, because it is between the both ventricle, but between both atria it is low pressure difference. Between the atria there is a low pressure difference zone. So question कि infective endocarditis is a complication of VSD or ASD? It is VSD because it's a high pressure gradient na. So what happens if it is high pressure gradient, then the blood will be forcefully, you know, coming into the right ventricle, and that will injure the right ventricular endocardium. So that will further increase the risk of infective endocarditis. As ASD is low pressure zone, low pressure gradient is there, so that the blood flow cannot injure the endocardium. Now why there is fixed splitting in ASD? So we have understood that in ASD there is a low pressure. So we have understood that in ASD there is low pressure difference between both the atria. Okay. So suppose because of this atrial septal defect, during atrial contraction, X amount of blood is actually reaching right atrium. Okay. This is the X amount of blood that is reaching the right atrium because of the defect. Now, because of the venous return, let's say because of the venous return, Y amount of blood is reaching. Because of the venous return, Y amount of blood is reaching. So what happens during ventricular diastole? This X plus Y amount of blood is actually present in this ventricle, right ventricle. Okay, X plus Y amount of blood will be present in right ventricle. Okay, and this same amount of blood will be ejected into the pulmonary trunk. Okay, so this is, suppose this is in case of expiration. This is in case of expiration. Okay, so X amount of blood is actually coming from the left atrium, and Y amount of blood that is normally as a venous return to the right atrium. So ultimately this X plus Y amount of blood is passing through the tricuspid valve, and through this tricuspid valve this blood is actually reaching the right ventricle, from where it is ejected to the right atrium, pulmonic trunk. Once we know that, let's discuss what happens in case of inspiration and why there is no variation of ASD S2 splitting. There is no variation, there is fixed S2 splitting. Now why? See, in inspiration what happens, as I told you, the venous return will increase, so this Y amount से ज़्यादा blood will be there. Inspiration में you will be having extra venous return. So let's say that extra venous return that is coming, that is X. extra venous return that is coming, that is x. So as you can see, because of the venous return, now the venous return to the right atrium is x plus y. Now the venous return to the right atrium is x plus y. Now because of this amount of blood, it will increase the pressure of the right atrium. And because of this increase in pressure, this will be now equals to the left atrial pressure. And that functionally that closes the ASD. So because of the atrial septal defect, because of inspiration, the extra amount of blood is there, and this extra amount of blood is actually inhibiting the flow through ASD. So now again this x plus y amount of blood is actually coming to the right ventricle. So you can see both in inspiration as well as in expiration, ultimately your right ventricle is receiving x plus y amount of blood. Okay, but the mechanism is different. Okay, so there is fixed splitting. Now you can say that yeah, there is fixed splitting, but why there is widening? So why there is wide split? Okay, now wide means, see, normally venous return mein y amount was coming, y amount should pass through this, but here x plus y amount is passing. That means the volume of blood that is passing through the right ventricle is more. So again the same funda, the right ventricular ejection time is increased. So the pulmonic valve will be in open state for a longer time. So A2 to ho gaya, but P2 will not be here. P2 will be delayed. So P2 will be like here. So ultimately you can see that this A2 P2 gap is now increased to this area. That's why you have splitting, and it is a fixed splitting. Now I think you understood that. So we have an example for fixed splitting is ASD. Okay, ASD. Okay. So we have a syndrome that is known as Hall-Toram syndrome, where the patient is having atrial septal defect associated with radius bone defect. Also, this is seen in Down syndrome. Okay, ASD is seen as a endocardial cushion defect. You will be having a Down syndrome. Then you have another syndrome, that is what is known as Luttenbacher syndrome. Where there is ASD associated with mitral stenosis. Okay. So this is just an example of fixed split. Coming to the variable split में बहुत सारा example है. Okay, one example you have is ventricular septal defect, because I told you it's a variable split. Why? Because in VSD it's a high gradient, pressure gradient is high. So even in inspiration, though the venous return is more, it will not functionally close the ventricular septal defect. Okay, so you'll be getting variable split. Okay, then is mitral regurgitation. You'll be having variable split. Next, see here, mitral regurgitation. Next, you'll be having WPW syndrome and right bundle branch block. I mentioned right bundle branch block because the conduction to the right side is decreased, so pulmonic valve will close after certain time. Again, this WPW type A is associated with variable split, whereas WPW type B is associated with narrow split. It is associated with narrow split. Okay, so let us talk about few other things. Here I just told you this splitting is same in expression and inspiration. Coming to paradoxical split, and there we'll complete our list of narrow splitting. Paradoxical split is actually seen in aortic stenosis. Aortic stenosis you can see this is left ventricle and this is aorta. Aortic stenosis means the orifice in severe aortic stenosis, the orifice is less than 1 centimeter square. The valvular orifice is less than 1 centimeter square. Now, because of the narrowing of aortic valve, what happens during ventricular systole? This amount of blood that is getting ejected out from this ventricle, okay, will be taking longer time because the valvular area is narrowed. So again, the same funda, the left ventricular ejection time will be prolonged. So now what happens? You have A2 and you have P2. This A2 will close after a certain period of time. So that is where the A2 P2 gap is actually decreased. So that's why it is causing narrow splitting. So narrow splitting, the first example will be aortic stenosis. The patient is not going for valvular replacement. So in that case, this aortic valve will further narrow, and this jet will be taking much more time to get ejected out. So there will be a time where this A2 will close along with P2. That will cause a single S2. So if they ask you ki absence of splitting in aortic stenosis is obviously denoting a severe variety of aortic stenosis. Okay, if there is absence of splitting in aortic stenosis, so normally you will be having a narrow splitting, but gradually the valve, as it there is no replacement, the replacement of valve is done, so gradually the orifice will become narrow, and then at a time there will be single S2. But even after that, the valve replacement is not done, what happens? The A2 will actually skip the P2 and overcome the P2, and first pulmonic valve will close and then aortic valve will go close. That is what is reverse splitting. That is what is reverse splitting, or which is also the paradoxical split, which is also known as the paradoxical split. Okay, so in case of AS, the narrow split followed by single S2 followed by paradoxical split is what is the severity of progression of the disease. Okay, so here this is heard in conditions that delay the aortic valve closure, like aortic stenosis. I told you right bundle branch block will produce wide split. So here the left bundle branch block, and also I told you type B WPW syndrome. Okay, there is paradoxical splitting that happens. So you can see you have HOCM, then you have type B WPW, even in left ventricular failure and left bundle branch block. These are the conditions where you will be getting narrow split. Okay, so this is what is your second heart sound splitting. Second heart sound splitting.